In this second lecture of Unit 1, we're going to be talking about renal anatomy and physiology and function testing. So how are the kidneys structured? How do they work? What is their function? So some of the basic functions of the kidneys is that they eliminate waste products from the blood, and it's through that process of constant filtration. They form urine, regulate water volume, regulate the body's salt content, regulate the body's blood pressure, regulate the pH balance in the body, produces hormones such as erythropoietin, and processes vitamin D. So the basic kidney structure, and I'm actually going to switch to this image of the kidney while I'm going through kidney structure just so you can have a visual while I'm talking about it. So the renal artery carries blood into the kidney from the aorta, which is the main artery in the human body that distributes oxygenated blood to all parts of the body through systemic circulation. And then the renal vein carries blood from the kidney to the vena cava, which is in the heart. The cortex is the outer covering of the kidney. The medulla is the central area in the kidney, which contains 8 to 12 renal pyramids. And then the renal pelvis collects urine from all the renal pyramids. And here's just another picture of some of those same structures with an outer and interior view of the kidney. Okay, the nephron is considered the functional unit of the kidney. Each kidney contains about 1 to 1.5 million nephrons, and the kidney contains two different types of nephrons. We've got cortical nephrons, which are located in the renal cortex, that make up about 85% of nephrons found in the cortex of the kidney. Their primary function is removal of waste products and reabsorption of nutrients. And then we have juxtamedullary nephrons, which are located in the renal medulla, that have longer loops of Henle that extend deep into the medulla of the kidney. Their function is to concentrate the urine. So some of the functions of the nephrons are controlled by renal blood flow, glomerular filtration, tubular reabsorption, and tubular secretion. So this chapter focuses on those four functions. Okay, renal blood flow. This is the path that blood takes as it enters and leaves the kidney. So first you've got the renal artery where blood enters the kidney, then it goes to the afferent arteriole, which carries blood from the renal artery to the nephron, where it then enters the glomerulus. The glomerulus is a highly specialized tuft of capillaries that are involved in that filtration process. That flows from the glomerulus into the efferent arteriole, so blood from heart to kidney by that renal artery. The efferent arteriole is smaller than the afferent and carries blood away from the nephron to the renal vein. The different sizes of the arterioles helps to create the pressure needed to maintain the consistency of capillary pressure and renal blood flow within the glomerulus. Blood then enters the peritubular capillaries in the vasa recta, which is a network of capillaries that surrounds the loop of Henle and the proximal and distal convoluted tubules. This allows for the immediate reabsorption of essential substances. It then moves on to the proximal convoluted tubule, which is the nearest tubule to the glomerulus, where reabsorption of essential substances begins. In the loop of Henle, this is the U-shaped part of the renal tubule that consists of a thin descending limb that leads away from the proximal convoluted tubule and a thick ascending limb that leads to the distal convoluted tubule. So this is where the major exchange of water and salts take place. This exchange maintains the osmotic gradient in the medulla, which is necessary for renal concentration. Then to the distal convoluted tubule. This is the part of the nephron between the ascending loop of Henle and the collecting duct where the final concentration of urinary filtrate begins. And then finally the renal vein, which is where blood leaves the kidney and returns to the heart. And here's, again, is just a visual of all of those structures. It starts in the glomerulus from afferent arteriole, and it kind of goes through that process there. So renal plasma flow is based on, and here's, excuse me, here's another picture of the glomerulus. And this has always reminded me, it makes me think of like a bowl of spaghetti. So you can think of the Bowman's capsule here as the bowl, and then the glomerulus is the spaghetti. Okay, renal plasma flow is based on an average body size of 1.73 meters squared of surface. Normal renal blood flow is approximately 1,200 milliliters per minute, and total renal plasma flow ranges from 600 to 700 milliliters per minute. So because of that, normal values for renal blood flow and renal function tests depend on the patient's body size. So when dealing with body sizes that vary greatly from that standard 1.73 meters squared, then a correction has to be calculated to determine if the result is normal. So we'll cover this calculation later when we talk about the GFR, or glomerular filtration rate. Okay, so getting into some glomerular filtration. Again, the glomerulus is a tuft of approximately 8 capillary lobes involved in filtration. So the glomerulus serves as a non-selective filter of plasma substances with a molecular weight less than 70,000 Daltons. So just anything, it's not picking and choosing on anything other than size at this point. The glomerulus is located in the Bowman's capsule, which is part of the nephron that contains the glomerulus. It forms the beginning of the renal tubule and collects the filtrate. It filters based on molecular size and the charge of the particle. So it's going to repel particles with a positive charge. The juxtaglomerular apparatus. Hold on, I think I'm getting behind on my slides here. So there's just another picture of the glomerulus as it sits in the Bowman's capsule. Okay, then the juxtaglomerular apparatus consists of juxtaglomerular cells in the afferent arterioles and the macula densa of the distal convoluted tubule. It regulates the sizes of the afferent and efferent arterioles in response to the body's fluctuations in systemic blood pressure, and that's in order to maintain consistent glomerular pressure. Okay, the renin-angiotensin-aldosterone system, or RAAS. This is what regulates the flow of blood to and within the glomerulus. The system responds to changes in blood pressure and plasma sodium content that's monitored by the juxtaglomerular apparatus. Low plasma sodium content decreases water retention within the circulatory system, so that results in decreased overall blood volume and subsequent decrease in blood pressure. The macula densa is located in the distal convoluted tubule, senses those changes, and a cascade of reactions in this RAAS system occurs. So the RAAS cascade starts with renin, which is an enzyme produced by the juxtaglomerular cells. It's secreted and reacts with a substance in the blood called angiotensinogen, and it produces angiotensin 1, which is an inert or inactive hormone. Angiotensin 1 then passes through the lungs, where angiotensin converting enzyme, or ACE, changes it to the active form, angiotensin 2, which corrects renal blood flow in the following ways. So it causes vasodilation of the afferent arterioles and constriction of the efferent arterioles. This stimulates the reabsorption of sodium and water in the proximal convoluted tubules and triggers the release of the hormone aldosterone from the adrenal cortex and antidiuretic hormone, or ADH, in the hypothalamus. So as systemic blood pressure and plasma sodium content increase, renin secretion decreases. So, and then again, there's a visual on that process if you want to take a minute to kind of look at and process that. And the glomerular filtrate. So as a result of those mechanisms that we just talked about, every minute approximately 2 to 3 million glomeruli filter approximately 120 milliliters of substances. So filtration is non-selective, so the only difference between the compositions of the filtrate and the plasma is the absence of plasma protein, any protein-bound substance, lipids, and cells. The ultrafiltrate of the fluid as it leaves the glomerulus should always have a specific gravity of 1.010, and this confirms that it is chemically an ultrafiltrate of plasma. Okay, in the process of tubular reabsorption, so when the ultrafiltrate enters the proximal convoluted tubule, the nephrons begin reabsorbing those essential substances. So some reabsorption mechanisms can be divided down into active and passive transport. So with active transport, for this to occur, the substance that is to be reabsorbed has to be attached to a carrier protein contained in the membranes of renal tubular epithelial cells, and the process also requires cellular energy. Active transport is responsible for glucose, salts, and amino acids in the proximal convoluted tubule, and then chloride in the ascending loop of Henle, and sodium in the distal convoluted tubule. With passive transport, movement of molecules across a membrane as a result of differences in their concentration or electric potential on opposite sides of the membrane is occurring. So passive reabsorption of water takes place in all parts of the nephron except for the ascending loop of Henle because the walls are impermeable to water. Urea is passively reabsorbed in the proximal convoluted tubule and the ascending loop of Henle, and passive reabsorption of sodium accompanies the active transport of chloride in the ascending loop. Maximal reabsorptive capacity. So when a substance that is normally completely reabsorbed reaches an abnormally high level in the body, the substance has reached what's referred to as the maximal reabsorptive capacity. So the body's reabsorbed as much of that substance as it can't hold on to any more. So at that point, that substance will start appearing in the urine. The plasma concentration at which active transport stops is referred to as the renal threshold. So for glucose, that renal threshold is 160 to 180 milligrams per deciliter. So when you're seeing blood glucose levels that are within normal limits, but you're seeing glucose in the urine, this indicates some type of renal tubular damage. Tubular concentration. Water is removed by osmosis in the descending loop of Henle due to the high concentration in the renal medulla. Then sodium and chloride are reabsorbed in the ascending loop. The walls of the ascending loop are impermeable to water, so and that's to prevent the excessive reabsorption of water. Concentration of the filtrate leaving the ascending loop is low because sodium has been reabsorbed and not water, and reabsorption of sodium continues in the distal convoluted tubule and is now regulated by aldosterone, which is the hormone, which regulates reabsorption in response to the body's need for sodium. Again, just a visual of kind of what's being reabsorbed and secreted. Then in the collecting duct, this is where the final concentration of the filtrate happens, beginning in the late distal convoluted tubule and continuing into the collecting duct. Water reabsorption depends on the hormone vasopressin, which is just another name for antidiuretic hormone, or ADH, which is determined by the body's state of hydration. So ADH renders the walls of the distal convoluted tubule and collecting duct as either permeable or impermeable to water based on that state of hydration. So when the body is dehydrated, the body produces ADH, which increases permeability. So that allows the body to reabsorb the water that it needs. And that results in a low volume, more concentrated urine. But when the body is hydrated properly, ADH production is down, which renders the walls impermeable to water, meaning that they're not going to reabsorb water because the body doesn't need it. So that's going to result in a large volume of dilute urine. Visual on that. So increased or adequate body hydration decreases the formation and the secretion of ADH, gives us an increased urine volume because the body is getting rid of that extra fluid that it does not need. And then the opposite down here. Okay, next we're going to talk about tubular secretion. So this involves the passage of substances from the blood to the tubular filtrate as opposed to reabsorption, in which substances are moved from the filtrate to the blood. The two major functions of tubular secretion are in eliminating waste products and regulating acid-base balance of the body. So it eliminates waste products not filtered by the glomerulus. So many substances like medications cannot be filtered by the glomerulus because they're bound to plasma proteins. So these substances dissociate from the protein when they enter the peritubular capillaries. That results in their transport into the filtrate by tubular cells. The proximal convoluted tubule is the major site of removal of those non-filtered substances. And then for regulating the acid-base balance in the body, it does this through the secretion of hydrogen ions. In order to maintain the normal blood pH of 7.4, the blood must buffer and eliminate the excess acid formed by dietary intake and body metabolism. So the body does this through three processes that occur simultaneously at rates determined by the acid-base balance in the body. So it does this through bicarbonate. So the buffering capacity of the blood depends on bicarbonate ions, which are already filtered by the glomerulus and have to be returned to the blood to maintain proper pH. Secretion of hydrogen ions by the renal tubular cells into the filtrate prevents the excretion of bicarbonate because it has to counteract the acidic environment that the hydrogen ions cause. So it does this in the urine so that the filtered bicarb is returned to the plasma. Then with phosphate, hydrogen ions are small and easily reabsorbed, so the actual excretion of excess hydrogen ions also depends on tubular secretion. So the secreted hydrogen ions combine with a filtered phosphate ion instead of the bicarb ion, and it's then excreted rather than reabsorbed. And then ammonia. So in the proximal convoluted tubule, ammonia is produced from the breakdown of the amino acid glutamine, and it reacts with the hydrogen ion to form the ammonium ion, which is then excreted in the urine. The distal convoluted tubule and the collecting duct are also able to produce ammonium ions if there should be a need to get rid of any additional hydrogen ions. So that process with the bicarb, the ammonia, and the phosphate are what helps to regulate our body's pH. And now we're going to talk a little bit about some different renal function tests. So these tests are used to evaluate glomerular filtration, tubular reabsorption, tubular secretion, and renal blood flow. Glomerular filtration tests. So these are used to measure the filtering capacity of the glomeruli. They get referred to as clearance tests, and they measure the rate at which the kidneys are able to remove a filterable substance from the blood. So some factors to consider when selecting a test: the substance to be analyzed must be one that is neither reabsorbed nor secreted by the tubules in order to ensure the glomerular filtration is being measured accurately. the stability of the substance during a possible 24-hour collection period, plasma level consistency, and the substance's ability to the body and the availability to the body and the availability of the tests to analyze the substance. Primary substances that are evaluated in clearance tests include creatinine, beta-2 microglobulin, cystatin C, and possibly radioisotopes. The only one that we're going to talk about is creatinine. So creatinine clearance test, which is also known as a glomerular filtration rate, is the most commonly used test. It must be performed as a 24-hour collection, and a serum sample must be collected and analyzed at the same time as a comparison. Some of the advantages to this test: creatinine is a waste product of muscle metabolism, and so it's going to be found at relatively constant levels in the plasma. And there are automated chemical tests that make it easy to perform, but there's also some disadvantages to this test. So some creatinine is secreted by the tubules if found in high enough levels in the blood. Also chromogens, which are substances found in organic fluids that form colored compounds when oxidized. So chromogens present in human plasma react in the chemical analysis. Medications can cause interference and cause falsely low serum levels. Bacteria can break down creatinine in urine if specimens are left at room temperature for extended periods. Patients on heavy meat diets during the collection time could have a alteration in their results. Measurement of creatinine clearance would not be accurate in patients suffering from some type of muscle wasting disease, and accurate results depend on the accurate completion of the 24-hour collection. So if it's not collected properly, then the result's not going to be accurate. And then the fact that the result has to be corrected for body surface area if the patient's body is far outside of that normal limit, and always has to be corrected for in children. Okay, the principle of the creatinine clearance test is to determine the amount of creatinine completely removed from the plasma during 1 minute. So the result is reported in milliliters per minute. That's referred to as the glomerular filtration rate. The greatest source of error in any type of clearance procedure is the use of improperly timed urine specimens. So again, it's just very important to make sure that the patient has adequate instructions and collects that specimen properly. So measurements that are required for the procedure are the urine volume in milliliters per minute, the urine creatinine result in milligrams per deciliter, the plasma creatinine in milligrams per deciliter. So the calculation of the urine volume has to be determined by the number of milliliters per minute collected. So you have to divide the number of milliliters in the specimen, which is your total volume, by the number of minutes used to collect the specimen. So the collection period should be 24 hours. So if there are 24 hours in a day, 60 minutes in an hour, 24 times 60 is 1,440 minutes for a day's collection. So if the volume also were 1,440 milliliters, then you would divide 1,440 milliliters by 1,440 minutes, and the result would be 1 milliliter per minute. So that standard creatinine clearance formula is urine creatinine times urine 24-hour volume divided by plasma creatinine by the time, your 24-hour time, which is 1,440 minutes. So you can do a practice calculation there. Okay, normal values for creatinine clearance. So creatinine is produced as a result of muscle destruction. So normal values are going to be based on a person's size. So the larger the person, the more creatinine that would be produced. So men's normal range is considered 107 to 139 milliliters per minute because they naturally have more muscle than women. And for women, the normal range is 87 to 107 milliliters per minute. So values are also going to be lower in older people because they generally will have lower muscle mass. And there are charts that are available to adjust for size. Clinical significance of creatinine clearance tests. So the results of this test are based on functioning nephrons, and nephrons can double their workload if they have to, like you would see in people with only one kidney. Creatinine does not detect early disease, but it can monitor the extent of known renal disease, and it can determine the feasibility of administering medications that may build up to toxic levels. The estimated glomerular filtration rate are formulas that are used to predict the glomerular filtration rate from the serum creatinine results. So variables for this method include sex, weight, and age of the patient. This method is useful when you're trying to monitor diagnosed renal patients or patients considered to be at risk. So diabetic patients would be considered at risk. Also in determining the feasibility of administering medications. So just trying to decide, will the patient be able to process the medication properly? Okay, next we're going to talk about some tubular reabsorption tests. So the loss of tubular reabsorption capability is oftentimes the first function affected during renal disease. Concentration tests are those used to determine the ability of the tubules to reabsorb the essential salts and water that have been non-selectively filtered by the glomerulus. And the baseline for determining that concentration is that 1.010 specific gravity of the original ultrafiltrate. Osmolality or osmolarity measures only the number of particles in a solution. So it's not influenced by the density of the particles. Osmolality is a more accurate evaluation of renal concentrating ability than specific gravity. And there are two methods of measuring osmolality. So we have a freezing point method and a vapor pressure method. The freezing point osmometers determine the freezing point of a solution by It does this by supercooling the sample. Then that supercooled sample is vibrated to produce crystallization of water in the solution. Then the heat of fusion produced by the crystallization temporarily raises the temperature of the solution to its freezing point. The temperature increase is measured and corresponds to the freezing point of the solution. So the freezing point of the unknown solution is compared to the freezing point of a known solution. So the osmolality of the unknown can be calculated. And then with vapor pressure osmometers, they actually measure the dew point, which is the temperature at which water vapor condenses to a liquid. The dew point temperature is proportional to the vapor pressure from an evaporating sample, and temperatures of unknown are compared to temperatures of the known solution, and the results are converted to milliosmoles. This method has been shown to have more variation than the freezing point osmometers. Then here's a picture of a freezing point osmometer, and it's a very simple test to perform, but there are a lot of controls usually that have to be run along with your patient sample, so it can be a pretty time-consuming process. The ratio of urine to serum osmolality is a more accurate evaluation of renal concentrating ability than just the urine result. Since factors like fluid intake and exercise can so greatly influence the urine results. So under normal random conditions, the urine to serum osmo ratio should be 1:1, but after a controlled fluid intake, it should be 3:1. The clinical significance of these concentration tests, so they're valuable for evaluating renal concentrating ability, for monitoring the course of renal disease, for monitoring fluid and electrolyte therapy, in the differential diagnosis of hyper versus hyponatremia, which is high and low plasma sodium levels, and also in evaluating the secretion in response to ADH. So that was a little bit of information on renal anatomy and function. The last video for Unit 1 will be on the physical examination of urine.